know about my leptospirosis, but one important thing that I realized during preparation of this presentation is I don't know much about leptospirosis. We have already discussed about the epidemiology of leptospirosis. During outbreaks, large number of patients get admitted to medical wards. Some of them develop organ failures, some of them develop life-threatening complications, and some of them die. Leptospirosis generates a huge workload in medical wards and causes an extra burden to the subspecialties. The burden caused by leptospirosis is sometimes beyond the capacity to manage, leading to burnout of the workforce, which in turn lead to poor quality of care. The time and the resources that could be utilized for other patients are compromised, especially in critical care settings. That is why we thought of organizing an eye-opening campaign with regard to leptospirosis in Nuwan district, and this is the first step in that process. In my presentation, I'm not going to tell you about new things. These are the simple facts you know about leptospirosis from your medical school days. I'm trying to refresh your knowledge in order to encourage you to detect leptospirosis early and to improve and to provide some guidance to initial management. Also to discuss some aspects about prophylaxis. My entire presentation will be based on two documents. That is, one is this CME article written by Professor Senaka Rajapaksha on clinical medicine 2022 and national guidelines on management of leptospirosis 2016. Nearly all mammals can serve as carriers of leptospirosis, harboring and shedding the organism from the proximal tubules of the kidneys. The rat is by far the most important carrier responsible for human leptospirosis. Rats treat very high concentrations of organisms, even several months after initial infection. The commonest means of transmission to humans is through abrasions on skin mucous membranes coming into contact with water contaminated with infected animal urine. Human leptospirosis has diverse clinical manifestations. Clinical illness in humans can range from mild self-limiting acute febrile illness to severe life-threatening condition with multi-organ failure. Clinical manifestations can mimic other illnesses and sometimes difficult to distinguish from many other infectious diseases because symptoms and signs are overlapping. Dengue can be difficult to distinguish from leptospirosis because both are febrile illnesses and can range from mild disease to severe illnesses with hemorrhages. Jaundice is uncommon in dengue. Sometimes the investigations can help to differentiate between leptospirosis and dengue. We expect leukopenia and thrombocytopenia in dengue and leukocytosis and thrombocytopenia in leptospirosis. Classically, CRP is negative in dengue and positive high in leptospirosis. Serum creatinine is normal in dengue fever, and if there's renal involvement, the creatinine will be high in leptospirosis. Sepsis may be difficult to differentiate because of multi-organ involved. Rickettsial infections have similar laboratory findings, so it is difficult to differentiate. Scrub typhus presents similar to acute phase of leptospirosis. A distinguishing feature is the rash also involving the body and the face, and the edge scar at the site of the bite and the regional lymphadenopathy. Hantavirus and other hemorrhagic fevers can present with renal, pulmonary, and ophthalmic complications similar to those observed in leptospirosis. Acute viral hepatitis, especially hepatitis A, can present with fever and jaundice, but renal and pulmonary involvement are uncommon in viral hepatitis. Incubation period is usually 5 to 14 days with range of 2 to 20 days. The clinical course of leptospirosis has been classically divided into two phases, that is leptospiremic phase or acute phase and immune phase. The initial bacteremic phase or the leptospiremic phase, there is an acute onset fever with chills and rigors, headache, myalgia, nausea, vomiting, and conjunctival suffusion usually appears in the third day of the illness and is characteristic but not non-specific. Myalgia can be severe, and muscles involved are calf muscles, abdominal muscles, or paraspinal muscles. Calf muscle involvement is classical, and gastrocnemius muscle tenderness is a classical feature in leptospirosis. When the abdominal muscles are involved, it can mimic acute abdomen, and the involvement of paraspinal muscles results in meningism. During the immune phase, where the IgM antibodies appear in blood and the organisms are excreted in the urine, and these organisms settle in higher concentrations in the PCT or the proximal convoluted tubules of the kidneys and other organs during this phase. Depending on the degree of organ involvement and the virulence of the organism, serious manifestations occur during this stage. So basically, patient becomes symptomatic during the leptospiremic phase, and they develop life-threatening organ involvement during immune phase. In practice, this differentiation into phases is difficult because there is an overlapping between these phases. Most of the patients recover from these two phases, but small number of individuals, there is persistent fever with development of jaundice, acute kidney injury, and other serious organ dysfunction. The classical triad of severe leptospirosis described by Weil in 1886 consisted of fever, jaundice, and splenomegaly. But currently, Weil's disease is used to describe as severe leptospirosis with predominant hepatic involvement and acute kidney injury. This is bilateral conjunctival suffusion, which is a characteristic feature in leptospirosis. Hepatic involvement is one of the commonest manifestations of severe leptospirosis and is seen universally when multi-organ dysfunction is present. Usually we see a cholestatic picture, that is raised conjugated bilirubin, that is conjugated hyperbilirubinemia, and raised AST, ALT, and alkaline phosphatase, but prolongation of prothrombin time is uncommon, but can happen in acute massive hepatic necrosis. Pulmonary manifestations It's a frequently seen in symptomatic leptospirosis with severity ranging from non-productive simple dry cough to pulmonary hemorrhages. Pulmonary hemorrhages has recently been shown to be an important cause of mortality. Pulmonary involvement is one of the predictors associated with worse outcome. There are two main patterns of pulmonary involvement. They are pneumonitis with or without pulmonary hemorrhages and acute respiratory distress syndrome, ARDS. We have to suspect pulmonary involvement in a leptospirosis patient if the patient complains of cough, breathlessness, and hemoptysis, and also we see the patient is tachypneic, and when we can hear, when we can auscultate crackles and wheezes from cardiac crepitations. Chest X-ray characteristic findings of pulmonary involvement are bilateral diffuse air space disease, and this is the commonest finding. And if we are lucky to do a CT chest, we can see bilateral ground glass opacities, mainly in the peripheral and lower zones. These are serial chest radiographs of a 33-year-old man with confirmed leptospirosis who developed mild hemoptysis and hypoxemia. This was downloaded from internet. Image A shows normal image on day 4 of the illness. B shows a patchy airspace opacities developed involving both nerve fields on day 7, and C, a worsening diffuse airspace opacification on day 8. And this chest X-ray was taken at follow-up at 3 months, and it is completely normal again. Rhythm abnormality is a common finding in patients with leptospirosis. It is postulated that electrolyte imbalances and as well as direct myocardial inflammation is the cause of ECG abnormalities. Relative bradycardia, atrial fibrillation, atrial flutter, and ventricular premature beats are the common arrhythmias. Pericarditis and myocarditis can complicate leptospirosis, but cardiac failure due to myocardial dysfunction is rare. Though the typical clinical picture of severe leptospirosis is well established and easily recognizable by experienced clinicians in endemic areas, rare and unusual clinical presentations can cause diagnostic confusion. I would like to recommend you to read this article written by, again, Professor Senagraj Baksha and al. About this is a review article on atypical manifestations of leptospirosis, and it's a very good article. So atypical and unusual manifestations have been reported with human leptospirosis, including nervous system. They can present with features of encephalitis, hydrocephalus, ADEM, like Guillain-Barré syndrome and mononeuritis multiplex, and also cerebellar syndromes. And hematological involvement can be pancytopenia, hemolytic anemias, and hemolytic uremic syndrome, and thrombotic thrombocytopenic purpura. Patients can present with features suggestive of acute cholecystitis and pancreatitis. Also, they can have uveitis, optic neuritis, and palpitation. This is a summary of atypical manifestations of leptospirosis. Coming to a case, a 38-year-old farmer from Carter-Castilla presented with high-grade fever for 3 days with chills, backache, myalgia, and headache. He was apparently well with no significant past medical history. So, what do you think? What is your differential diagnosis? So this is, we don't have time to discuss. So probably this is a probable suspected case of leptospirosis. What are the features suggestive of leptospirosis? high-grade fever, headache, arthralgia, severe myalgia in calves and backache. And patient is from Cartagena endemic area, and he's a farmer. So unless proven otherwise, this is leptospirosis. On examination, he was unwell, dehydrated, conjunctival suffusion, calf muscle tenderness, and icteric with these other features of few lung crackles. And what are the features favoring leptospirosis in clinical examination? Conjunctival suffusion, muscle tenderness, icterus, lung crackles, and right hypochondrial tenderness. Let me introduce you to the case definition of leptospirosis in guideline published by Ministry of Health. This is the case definition given in National Guidelines of Sri Lanka. They classified as suspected case of leptospirosis and confirmed case of leptospirosis. So they, if a patient has acute febrile illness with at least one of the following, these classical symptoms or history of exposure or evidence of organ involvement, then we classify it as a suspected case of leptospirosis. What is important is suspected leptospirosis is a notifiable disease in Sri Lanka. They have defined the history of exposure like this. So high risk occupation, recreational activities, contact with potentially contaminated water, and other things. Confirmed case is a clinically suspected patient with laboratory confirmed leptospirosis. We have already discussed about that. Management of leptospirosis. So coming back to this case, I would like to know from the audience, how are you going to manage this patient? The first thing you need to decide is whether you are going to manage this patient outpatient or inpatient. What do you think? Hands up, those who think that we can manage this patient as an outpatient basis, and those who think we should admit this patient. So almost all think that we should admit this patient and manage. So how do we, what factors decides whether you are going to manage the patient outpatient or inpatient? So we can manage patients as on outpatient basis if a suspected case of leptospirosis with no organ involvement or no significant comorbidities. And the antibiotic therapy recommended is doxycycline 100 milligrams twice daily for 7 days. But you have to arrange these investigations at the first contact, and you have to review the patient in 48 hours. And you need to ask the patient to monitor urine output, and so you review the patient after 48 hours, and if there's an appearance of jaundice, reduction in urine output, if there's features suggestive of lung involvement, you should admit the patient. And if no admission is needed, you have to review the patient after another 48 hours. So, but it is important to make sure that the patient is compliant with your advice. Monitoring the urine output, looking for symptoms and signs is crucial. If there is a slightest suspicion of a patient not being compliant, you have to admit the patient and manage inpatient. So a suspected case of leptospirosis with organ involvement or significant comorbidities, you need to admit that patient. So how do you decide whether the patient is having organ involvement? The criteria are given in national guidelines. So these are the things they have mentioned to look in the patients for evidence of hepatic involvement, And these are the evidence for pulmonary involvement, and these features suggestive of cardiac involvement, and this is uh, evidence to suggest renal involvement. And you can consider hematological manifestation as also as organ involvement. So if the patient has suspected leptospirosis with organ involvement, you have to admit the patient. The antibiotics recommended in national guidelines is penicillin G 1.5 million using 6 hourly, or ceftriaxone 1 gram twice daily, cefotaxime 1 gram 6 hourly. And if the patient is penicillin allergic, you can give doxycycline. Patient should be managed in high dependency unit with cardiac monitoring, and patient should have access to oxygen. These investigations should be arranged during the admission to identify the probable organ involvement and life-threatening complications. Strict fluid management, monitoring of intake and output is necessary. And in patients with normal urine output, fluid therapy should be guided by clinical status. And in oliguric patients, you have to calculate the previous day output and estimate and get the estimated insensible loss. So what is important is you need to do a strict fluid management in these patients, and you have to take actions if there are any electrolyte imbalances, and you should omit potential nephrotoxic and hepatotoxic drugs, and non-steroidal anti-inflammatory drugs should be avoided. If the patient is diabetes, you should start on insulin, and the use of high-dose corticosteroids. This is the thing that everybody want to have an idea. The use of high-dose corticosteroids for treatment of leptospirosis is not supported by high-quality evidence, and routine use is not recommended. This is the guidance given by National Leptospirosis Guidelines 2016. But we know some studies have shown the bolus methylprednisolone given within the first 12 hours of the onset of respiratory symptoms may improve the prognosis and reduce the delay need for mechanical ventilation in pulmonary leptospirosis. But the strength of evidence is low. No specific treatment is needed for liver involvement. You can give N-acetylcysteine if patient go into acute liver failure. These are the indications for platelet transfusion and platelet and FFP transfusion, and you have to transfuse blood if the HB is low. There is no validated scoring system to predict severity of leptospirosis, but there's evidence that following are associated with severe disease: old age, chronic alcohol abuse, leukocytosis, low packed cell volume, hyponatremia, and so supportive care and antibiotics remain the mainstay of management in leptospirosis, and there are as yet non-specific therapies which influence outcome. Prevention: doxycycline 200 mg weekly, commencing 1 week prior to exposure and continue through the period of exposure is recommended. This is the best evidence for the use of doxycycline as a chemoprophylaxis for leptospirosis is provided by a double-blinded randomized control trial conducted in Panama in 1984. This study was conducted among 940 soldiers, and there's a significant reduction in number of cases. The weekly dosing method has been used by this study, and it is considered a practically feasible and an effective option. So decision to give chemoprophylaxis is made by the public health authorities, it should be closely monitored by MOH and the field public health staff. PHI could be involved in issue of medicine. The relevant MOH should strengthen the disease surveillance activities in their areas, especially where prophylaxis is provided. This is the last slide. Doxycycline can be taken with or without food, preferably with a glass of water. And this is what should do. This should be remembered by everybody. These are the contraindications for doxycycline. Age less than 12 years, in pregnancy, in lactating mothers, and in the presence of previous allergy, you can't give doxycycline. No human vaccine is currently available. Thank you.